Hi, everyone. Good evening, and thank you so much for joining NATF's Ask the Expert. Before we get started, just a quick announcement about asking questions. Everybody will be muted, so you won't be able to ask a question or raise your hand verbally. So we encourage you to use the questions function that's on your toolbar, which should appear on the right-hand side of your screen. You can submit those to the entire group, or if you prefer to submit them privately, you can definitely do that to me as well. So I would like to now introduce our host for this evening, Tara Lech. She is a pharmacist and anticoagulation and cardiovascular clinical pharmacy specialist. She currently serves as the Thrombosis Program Manager at Lahey Hospital Medical Center in Burlington, Massachusetts. In 2008, she completed 2 years of residency training in pharmacotherapy and cardiovascular medicine at UMass Memorial Medical Center, and she is board certified in pharmacotherapy. Her primary interests and area of focus include anticoagulation management, patient education, heart failure, and cardio-oncology. And we always get a lot of questions from patients about anticoagulation, and we could think of no better person than Tara to answer them. So welcome, Tara, and thank you for joining us this evening.
Thank you for the wonderful introduction. Thank you for having me. I'm really excited to be here to answer all of your questions tonight and see what you want to know.
Great. Well, so I wanted to start first. When I was reading your bio, the title Thrombosis Program Manager. So I've never heard that title before. It sounds important. It sounds like something that should be at a lot of institutions, but might not be. So I was kind of wondering if you could talk a little bit about, what that entails and what you do on a day-to-day basis.
Absolutely. So that was a title that we came up with my director of the anticoagulation clinic and the vascular medicine department. And it just means that I keep a close eye and watch and help with anticoagulation in all aspects of care. And one of my big focus is in the outpatient setting, making sure that our patients are safe. Our clinic primarily now manages Coumadin patients. We're looking to expand to DOAC patients in the future, and we do have a couple of patients that are on injectables only. My department also has pharmacists and nurses that focus specifically on transitions of care, which is a unique part of an anticoagulation program. So what they do is they assess every patient at discharge who leaves on an anticoagulant to make sure that they're safe, that if they were prescribed Coumadin in the hospital, that they have a manager for that Coumadin when they go home. Or if it's us, we get them enrolled in the clinic. We update their profile if they're historically already with us so that we know what happened during their hospitalization. And if they're not with us, we would contact, other hospitals like the Brigham or Mass General or Lowell General and say, hey, your patient came here. You might not know what happened, but we can send you the discharge somewhere. We can let you know the doses of anticoagulation they got in-house, any new meds, to make sure that that handoff is warm and safe. We also follow DOACs on the outpatient side too to say, hey, your patient was discharged, their dose was changed. Their dose may not be appropriate for their renal function or their hepatic function, and try to do everything in our power to keep it safe. And then I also sit on various committees within the hospital that take a look at inpatient order sets for our own hospital at Lahey, Burlington, and Peabody, but also for our system of hospitals. So we also look at Beverly and Winchester Hospital as well.
Okay.
So busy.
It certainly sounds like it, and it makes me kind of think that somebody realized that, patients with blood clots are complicated, and they really require kind of that extra attention to make sure that they're taken care of safely, because there's a lot going on there. And so it certainly sounds like, it keeps you busy.
Yes.
Helps keep
well, especially with the DOAC patients, when they leave, they don't have that same touch point that a Warfarin patient's going to have. They don't have a clinic or a primary care provider or cardiologist calling them to follow up. So a lot of times we will call them to say, did you pick up your medication? And there are times when, patients, wait a day or two to pick up a medication, but if you have an acute clot, you can't wait that day or two. You have about a 12 to 24-hour window, depending on what medication you're taking. So we're helping to make sure that they can pick it up, that it's not cost prohibitive, and if there is a glitch, that we can communicate back to their primary provider to let them know that we may need a new plan.
Mm-hmm. Now, you mentioned that anticoagulation clinic at Lahey is really a warfarin clinic,
Yes.
you know, a concomitant clinic, which is, I think, kind of how all of these different clinics started. And like you said, you're trying to transition to be more of an anticoagulation clinic. So will this be providing patients on the new class of anticoagulants with more touch points? Is that kind of the intent behind this?
Yeah, and it's not to alarm patients either, because we don't want to treat the DOACs, like the rivaroxaban, apixaban, dabigatran, edoxaban. We don't want to treat those patients like they're a warfarin patient. It's not meant to be checking in every week or every other week, but it's just a touch point to say, hey, you know, every year as you age, we need to make sure we evaluate your renal function, your liver function. And if patients are of an advanced age or have other comorbidities, then it might go from, you know, once a year to every 3 months or every 6 months, just to make sure that the medication is safe and appropriate. Also, we find too that sometimes medications are started in the hospital and may not be needed lifelong. So giving that touch point to say, hey, let's reevaluate, let's see if we can de-escalate therapy or see what's going on. Also making sure that the patients are still picking up their medication, because a lot of times the med will stay on a patient profile, but it doesn't always mean that the patients are picking it up. And a lot of times when physicians are moving quickly, or, you know, it's a short-in visit, you look at the med list, you see the patient's on the right drug for the right problem, and the visit just goes on. Mm-hmm. So really making sure that the patients aren't coming up with any barriers like a donut hole or just inability to get a med, or I forgot to ask for refills.
Wow, well, that sounds like an awesome service that a lot of patients would benefit from if, you know, when it becomes more widely available.
Yeah.
So, well, that was the easy part of this evening. So now we're going to dig into the hard part. So the questions that we got from the audience, which you commented before we started, that a lot of them were really, you know, thought-provoking questions and things that as a clinician you might not necessarily think are on patients' minds.
Yes.
So we received a lot of questions about INR and related to INR this month. Before we dig into those, can you talk a little, just give us a brief overview of what INR is, why it's important, and what the different therapeutic levels mean?
Yeah, absolutely. So for patients that are on warfarin, the INR is important because that's, you know, the value that we use to tell how thin or thick your blood is. And so in a patient that does not take an anticoagulant, it should be 1 at baseline, and that would be normal. If we know that you have a clot or we know that you have a risk of stroke, we don't want to see that number be 1 when we check your INR. We want it to be in a range that's a little bit higher. So 2 to 3 is typically the range that we use for most patients. Our AFib patients, our DVT patients, our PE patients, they're all getting that same goal. There is a select group of patients that gets a higher goal of warfarin, 2.5 to 3.5, and we typically reserve that for our mechanical mitral valve patients, just because from the mitral valve, there's a decrease in your blood flow, so it's a slower flow through that valve. So there's more chance for the blood to pool and clot, and if blood pools and clots on that mitral valve, you're at very high risk for having a stroke. So we don't want to risk you being subtherapeutic. So, you know, if you're a little bit below your goal, you're still within that 2 to 2.5, which is still pretty good, but ideally we want to see you at 2.5 to 3.5 at each follow-up. And then sometimes you may not have a mechanical mitral valve, but you may have a higher goal range, and that might be because you've had recurrent clots on either warfarin or other anticoagulants. So maybe we're escalating from the traditional 2 to 3 goal range to the higher goal range to try to prevent you from having clots in the future.
Now, just to be clear, if you're not on warfarin, if you're on one of the newer anticoagulants, you do not want to get your INR checked.
No, we recommend against it because the drugs, especially apixaban, rivaroxaban, can have an impact on the INR. Not significant, and it's not measured and calibrated in the same way that we do for warfarin, so it's not meaningful. If you were to get an INR of 1.4, 1.5 on your, you know, DOAC, it's not the same as saying that your INR is 1.5 on Coumadin. So sometimes providers might see that, or patients might see that and get nervous and hold a dose or stop the medication, and that's not always appropriate. So we want to make sure that we are only monitoring appropriate levels, and INR would not be considered an appropriate drug level for that drug.
Mm-hmm. Is there any way to monitor the new anticoagulants to see if they're working?
That would be the $1 million test. If they could figure out a good, clear, and consistent test that was easy for hospitals to have and use, I think, we would be in good shape. I don't think most people would need levels, and it wouldn't be to the point that we're checking for INRs, but it would be a good touch point to know that the patient's on the therapy and it's where we need it to be. Because the nice thing about a DOAC is that it has a very wide therapeutic index as opposed to Coumadin. So like with Warfarin, you need that INR goal 2 to 3. It's pretty tight and there's not a lot of wiggle room, and it can be challenging to stay in such a narrow window. But with DOACs, they found that you can be a wide range of body weight. You can have a wide range or fluctuation in your renal function where we can dose adjust, but pretty much all patients require the same dose for the same indication as long as their renal function is okay. But it would be nice to know, and especially in special patient populations, like if your renal function is changing, if you're very elderly, if you're very low body weight or very high body weight, to know where you're at in terms of, are you therapeutic or super therapeutic, which could be dangerous in terms of bleed risk, or subtherapeutic, which could put you at risk for clot or stroke. The only good test that we have out there, which is not really a good test, would be the 10A level, which is similar to what we use to monitor heparin or low molecular weight heparins. But the caveat for that is that these tests are not calibrated or made to measure DOACs. So getting a level on the drug, like a heparin assay of, or a 10A of 1.1, doesn't mean anything in terms of how anticoagulated you are. All it tells us as the clinician is, okay, there is still some drug on board. I don't know how much. I don't know how long it's really going to take you to clear it. I can follow these levels until they, are 0 if I'm waiting for you to eliminate the drug. But it doesn't give me a good sense or a good feeling of if you're reaching the target level consistently.
Mm-hmm. And so I always am worried about, scaring patients away from anything and, not being able to monitor the level of these DOACs, while you said in certain instances, that's not ideal. But generally they are considered very safe. And in fact, they tend to, have a slightly better safety profile than Warfarin does. So I just want to make it clear that we're not trying to, sway anyone's decision one way or the other, just, get all the facts out there.
Yeah, no, I think that they are, safe in general practice. And that's why when patients ask, should I be monitoring my, my levels? The answer is no, you don't really need to. The only times when it becomes appropriate is when they're in, higher risk patients where we don't have a lot of data, like we said, in the very elderly or the very morbidly obese, like greater than 150 kilos, or your patients that are only, 30 or 40 kilos. But in your average patient, 50, 60, 70 years old, average body weight, 80, 90, 100 kilos, there is really no need. It may be beneficial if you were going to surgery or, needed, if you were hospitalized, but other than that, on the day-to-day, these drugs have been studied extensively and found to be safe.
Great. So we got a bunch of questions about interactions with supplements and vitamins and how those interact with, Warfarin and the other anticoagulants. So can you talk about that for a bit?
Yeah, absolutely. So I think it's always, hard to navigate the world of supplements, and it's important to have this conversation with, your anticoag clinic, your provider, to make sure that they know what you're on, because not all of these supplements are benign, even though they're over the counter and easily available. We really have to know how they affect, your anticoagulation and your ability to either clot or bleed. And so that's why it's important to have these discussions. So some of the big ones that tend to come up in the clinic are turmeric, ginger, garlic powder. Sometimes people are taking ginkgo biloba, grapeseed oil, vitamin E, and fish oil. So all of these things, there's various, data points out there to look at, but like with turmeric, for instance, we do caution against it when patients are on blood thinners because the turmeric has a curcumin derivative, which is similar to coumarin, which is similar, warfarin. So we want to make sure if you're on that you're aware that, the reason why you're taking it and that that you're putting yourself at potentially an increased risk for having a bleed by being on that supplement. With ginger or cayenne, for example, if you're taking large doses, they have salicylate in them, so similar to aspirin. So they also can have an impact on your risk of bleed if you're taking large doses consistently. Vitamin E in high doses have found to have, deleterious effects as well. So if you're not, needing to be on vitamin E supplementation, we typically recommend against it and usually recommend that you get vitamin E in other sources like almonds or sunflower seeds or sunflower oil. Those are all really good sources for vitamin E if you feel that you need some supplementation in your diet. Garlic powder has some antithrombotic properties associated with it, so that's important too because in some literature, if you're taking very high doses of garlic or garlic every day, there's some like surgical literature that even says you should stop doing that 7 to 10 days before you go for surgery. So it's really important to be having these conversations with your providers and not just letting them know the prescription meds you're on. Ginkgo biloba is also another interesting one because that also has some fibrolytic properties to it as well. So drugs that we use to bust clots. So that in combination with anticoagulants can also confer an added risk of bleeding. Grapeseed oil is known to be a natural anticoagulant. Dong quai can increase your time to clot. So if you start bleeding and you're on an anticoagulant and taking that supplement, you can also run into issues. Another one that has come up before for me, and the first time I actually came across it was I had a patient in my prior hospital. I was working in a cancer center, and they told me that they were on nattokinase, and I hadn't heard of that before. And then when I looked into it, it's a natural blood thinner, and it can be pretty potent. So that in combination with an anticoagulant can also be dangerous. And in fact, some places in the literature says if you're on nattokinase, you would need to stop that 2 weeks prior to having any procedure done. So it's definitely important. And then St. John's wort, some people will take that for mood or helping with their, stimulus and getting some energy. And that is the opposite. That can actually decrease the efficacy of your anticoagulants by increasing the metabolism of those drugs. So you think you're getting the therapeutic benefit, but you might actually be subtherapeutic for periods of time. And the thing I always remind people as a pharmacist is that these supplements aren't regulated. So you have to be aware that what you're getting from batch to batch, manufacturer to manufacturer is not always the same. So that incurs a risk as well. Another thing I wanted to bring up too is especially now where the laws are changing, people have a lot more access to cannabis and CBD. And I think that we really need to destigmatize talking about it. You can't be afraid to tell your provider if you are, regularly using CBD oils or partaking in cannabis, because it does inhibit platelet function. It can decrease the effects of Plavix by interfering with metabolism if you're on antiplatelets. And then it also impacts the anticoagulants as well. It's been shown to increase the effects of warfarin by competing and interacting with the metabolism. So we want to make sure that we know when our patients are on it, because sometimes we have patients that go from rock stable INRs to having their INRs fluctuate, having critical INRs. And it isn't till, a few visits later that we find out that this has changed. So even though it's not a medication or necessarily a supplement you would get from the store, you do need to let us know. And same thing with DOACs, because it's actually the opposite. So when you're on, rivaroxaban and apixaban, it can actually compete with the metabolism and make those drugs less effective. So that's something that, the data is just so sparse. We don't know. So there's some data to say, yes, this could be a problem. And at the end of the day, because we don't know, we just need to be aware. and
Yeah.
need to have that. I think a big concept now in the anticoag world is this shared decision making. But in order for us to have this shared decision making and know what is the best regimen for you in terms of your anticoagulant therapy, how do we help you in terms of, knowing what supplements you're on, knowing what your anticoagulant therapy is, and finding that, utmost beneficial risk-benefit relationship where we're not putting you at harm, but we're helping you get the benefits that you need, or potentially too talking to your pharmacist or provider, because we might know of other alternative therapies that could help supplement with what you're trying to get these supplements to do that wouldn't be as risky or dangerous for you.
Yeah. So the goal isn't to get patients to stop taking something that, may be beneficial to them. It's really just to help them do it safely.
Exactly. That's what we tell our Coumadin patients all the time. I don't necessarily need you to stop, but I need to know what you're on, because if you're going to tell me that you're going to start a new supplement, you may have been stable on monthly checks or every 6-week checks, but if you're going to start a new supplement, I'm going to have you come back in a week or two to make sure that we keep a closer eye on you while this new, supplement starts, to see what kind of effect, because that's the other thing too. I mean, patients are all different. How something affects me is going to be different than how it affects you or the other people that are tuning in today. So we want to tailor care and make sure that you're safe and that we help you, achieve all of your healthcare goals.
So with cold and flu season right around the corner and COVID, I think I've seen a lot of things about vitamin C, vitamin D. Can you talk to those two specifically about, their interactions, if any, with the anticoagulants?
If you're taking vitamin C, vitamin D in normal doses, we wouldn't stop that. We would just not note it on your profile, see how you respond, and keep going. There's definitely different data emerging on vitamin C, vitamin D. Is it beneficial? Is it reducing risk for patients that develop COVID? So I know that it's very, patients are very interested in taking it, and it can be done safely. Like I said, it's just, we want to know what you're on so that we can keep a current list, and just know too, because if you might be on some natural vitamins or supplements and then add another one, and even if it's not interacting with the Warfarin or the DOAC, you might have supplements that interact with each other. So we can help you navigate that as well.
Okay. Let's see. So a lot of the supplements and vitamins that you mention, the garlic, the grapeseed oil, those sorts of things are things commonly found in foods. So what about your diet do you need to be aware of and kind of monitor? Of course, especially people on Warfarin are really familiar with, dark leafy greens and just be, careful around those or having a steady intake of those. But other concerns or things you should make your provider aware of with your diet?
No, I think the key, and this is what I tell all of our, Warfarin patients, is this drug is not a life sentence for you. We're not here to make your life miserable or restricted in any way. If you are someone that loves crop shares and, gardening, and you're eating fresh foods all the time, that's fine. Everything is in moderation. And you don't have to eat the same thing every day. You don't have to, count how many, micrograms of vitamin K are in every food you eat. That's not the design. And that's not what we want to do to our patients. What we just say is everything in moderation. You can enjoy garlic with your food. I wouldn't eat, 10 cloves a night every night. It's probably not the best, and you might not have many friends want to come near you, although I guess it would improve social distancing if you chose to go that route. But other than that, I mean, there's rarely anything that we would tell someone that they can't eat or enjoy. And same thing goes with alcohol. We're not saying you're on a blood thinner, you can never have a drink, always drink water or juice, but it's, have a drink or two. And, if you are going to an event or you're going, when people can go to events again. You know, if you're having a Super Bowl party or you're getting together with family or friends and you know you're going to be drinking a little more than normal, then you might not want to schedule your INR for the next day. Because you know you need to give your body time to level out. But it's just important to keep in mind that when you do that, you are increasing your risk of bleed. If you are having more than 1 to 2 drinks a night, if you are, you know, binge drinking, or and same thing too, if you all of a sudden you don't let us know and you change your diet and you decide to go, you know, vegetarian, that's fine. But you have to tell us, because your warfarin levels are going to be off and you might drive them down really low and put yourself at risk for a clot. So we would never say, no, you can't be vegetarian, or no, you can't decide to just eat, you know, salads every night. We would just say, okay, we'll come in, we'll check you a little more frequently, and we'll increase the doses of warfarin as appropriate to reflect your lifestyle.
Mm-hmm. Great. So you very much want to be a partner.
Yes.
And not a parent with these things.
We're not a blocker, we're a helper.
So kind of along the same lines, somebody was wondering, are there any foods that help reduce blood clots that do not interfere with blood thinners? And a follow-up question they had is, does dehydration contribute to blood clots?
So in terms of the foods, there's nothing I would really recommend in terms of a clot-friendly diet. I would say try to eliminate processed foods as much as possible, and clean eating is always beneficial for you. In terms of the dehydration part of that question, yeah, I mean, it's a risk factor for developing VTE. You want to stay hydrated. Your vessels are very compliant. So when you're not drinking enough fluid, your vessels can get smaller, and also the thickness of your blood can increase, and those things can put you at risk for having a clot. Especially too, now we have, you know, a lot of worry because of the social distancing, because of the quarantining, people just aren't as active. If you're staying in your house all day, it's very hard to get 10,000 steps in unless you are doing laps around your counter, which, you know, gets old after about 2 minutes, and that's not going to get you close to 10,000 steps. So if you're, you know, sitting on the couch all day, you're not eating and drinking, you are going to put yourself at an increased risk of an event. So you just want to make sure that you're not sitting for hours at a time or standing for hours at a time without, you know, compression hose or stockings if that's appropriate. You want to make sure that you're getting up, you're moving around, that you're eating and drinking. You know, I think the goal is 8 ounces every couple of hours to make sure that you're meeting your body's needs, and go from there. But yeah, I would try to avoid dehydration, especially now winter's coming, you know, making sure that we are taking care of ourselves more than just the quarantine part, but your health as well in terms of exercise, activity, and hydration.
So we talked about vitamins and supplements and food, but we also got some questions about other prescription medications in terms of preventing DVTs or using anticoagulants kind of to prevent things such as heart attacks. So specifically, somebody wants to know if a daily low dose of Lipitor can assist with preventing a DVT. If so, how?
Well, that's a good question. I think, you know, a lot of good things have come from the evolution of the statins. They have a lot of anti-inflammatory properties, which makes them very attractive medications. And there was actually a big study, not looking at Lipitor, but looking at Crestor, called the Jupiter trial. And in that dose actually used a higher dose of statin, so Crestor 20. And they did see lower incidences of DVT in those patients. And there have been other studies as well looking at simvastatin, pravastatin, and atorvastatin that have mixed results. And what we've seen is that some statins may be better than others, but that data is not all parched out yet. So the long and short of that is potentially yes, but there's not enough data to recommend it yet as an adjunct therapy. It would never replace what you need for an anticoagulant therapy, but there are studies looking at the potential role of statins as an adjunct to help further reduce those the risk of clot by adding those anti-inflammatory properties to your treatment.
So if you're taking it to lower your cholesterol, you may be getting some secondary benefit there, but you shouldn't be taking that for the sole purpose of preventing a DVT.
Correct. If you have an indication for it, then you should continue taking it, but we're not at the point yet where we would primarily prescribe it for adjunctive risk reduction for VTE.
Okay. Does being on an anticoagulant help prevent a heart attack?
So also another good question. I mean, they have, anti-thrombotic properties, which are beneficial. And there have been studies looking at warfarin primarily because warfarin's been around for, almost 100 years now. So when you have a drug that's that old, you have people that are going to study it in every way imaginable. And for a long time before we had the advent of a lot of the new antiplatelets like Plavix, ticagrelor, prasugrel, we had aspirin and Coumadin. So what we know from looking at the data is that warfarin does decrease the risk of acute coronary events, but you can still have acute coronary events if you are still on an anticoagulant. It does reduce them a little bit more than aspirin, but we know that if you don't have an indication for anticoagulation, if you don't have a reason to be on anticoagulation, we would prefer to use aspirin for prevention versus warfarin. And I think now, just a couple of years ago, a lot of studies came out looking at primary prevention anyways. And if you don't have risk factors, there's really no benefit for primary prevention. And you have to also worry about the increased risk of bleed by being on an antiplatelet or an anticoagulant. But if you do have an indication for anticoagulant therapy like AFib or a history of clot, then yes, it can offer some protection. But again, acute coronary syndrome, a myocardial infarction, that's a plaque rupture. So you're going to have an unstable plaque that ruptures. You're going to have a platelet aggregation response. So that's why if you end up having an MI, you are going to end up on an antiplatelet along with your anticoagulant, because for treatment purposes, the anticoagulant is not the appropriate therapy as monotherapy.
Okay, great. So a patient writes in that they have been unable to take warfarin. They can't maintain a stable INR. They've also had several blood clots. So they've discontinued the warfarin, and they're kind of wondering, they're looking for advice on what options are out there. And if you can, kind of talk about that, as well as how a patient could safely transition to an alternative. I know it's hard without knowing the ins and outs of the patient's case, but just generally speaking, if warfarin isn't working for a patient.
Okay, so there's a few different options. So I think in the first part of it, did you say that they were on brand name Coumadin? Is that what? On
brand Coumadin, yep.
So that's something that's good for everyone to know, is that the manufacturer of brand name Coumadin, Bristol Myers Squibb, has decided to discontinue brand name Coumadin. And I know that, patients tend to be very sensitive and say that when they're not on the brand name, when they're on just the generic warfarin, that their INRs are a lot more variable. We have not seen that in many patients, but there are a few that do have that issue. If you cannot be on an alternative anticoagulant because of your diagnoses, like if you had antiphospholipid syndrome or mechanical valve, or if it's cost prohibitive to be on a DOAC, then you may want to try Jantivin, which is the other brand name of Coumadin, which is still available. So the nice thing about the brand is, it tends to be a bit more expensive, less covered by the insurance in terms of copay, but it's a consistent manufacturer that makes that brand of warfarin, as opposed to generic warfarin, which you can get from various manufacturers. So that might be one option for you. If you do have the ability to be on an alternative anticoagulant, if it's appropriate for your diagnosis and it's not cost prohibitive, then you could try, one of the other anticoagulants, apixaban or rivaroxaban, and see if that would work for you as well. And it might, it takes away the whole worry about inconsistent levels, because we don't need to know your level. So that might be something to consider or look into. And as far as the transition piece, that always comes up too. It would be one thing, we love is consistency and the ability to kind of standardize everything. But unfortunately, when all of these drugs studied how to do the transition process, they all did it a little bit differently. So the acronym I give people to remember is READ. So rivaroxaban, edoxaban, apixaban, and dabigatran. So rivaroxaban, the package insert recommends it's safe to start once your INR is less than 3. With edoxaban, the package insert states it's acceptable to start when your INR is less than 2.5. And then for the apixaban and dabigatran, they recommend starting when your INR is less than 2. But it's always important to talk to your provider or your clinic, because they may have their own standard process where they just have everyone's INR be less than 2 before they transition. So usually what we'll do is we'll have the patients come in for an INR check. We'll see where they're at. And then depending on their risk, or if they really want to feel confident that their INR is truly low enough to start the DOAC, then we would just have them hold 1 to 2 doses of their warfarin, come back for an INR check, and then have them safely start the new anticoagulant.
Okay, great. So patients, and you mentioned this earlier, are on anticoagulants for a variety of reasons and for varying lengths of time. So this patient is wondering, if you have a stent placed in your iliac vein, should you stay on blood thinners indefinitely?
So I think that's a very tailored decision. I don't think it's a one size fits all. I think it's a question like that. You need to, talk to your vascular medicine physician or your vascular surgeon to make sure what's appropriate for you, whether it would be, lifelong anticoagulation only for a short duration, if they'd want you on antiplatelets. That is a very case by case scenario. There isn't a specific guideline to say all patients can stop at point X. So yeah, I would definitely defer that and make sure that you have a conversation with your provider that put in that stent, or your cardiologist, just to make sure you're touching base so that you're on therapy for the appropriate duration of time.
Okay. Always important to maintain a good relationship with your clinicians and really, discuss all the different options with them.
Yes.
So, okay. So this patient has been on blood thinners for over a month and they still have swelling in the ankle. Is that normal?
So I think it would depend on your lifestyle, your activity. If it's dependent swelling from being on your feet all day, that's one thing. But if you think that it's because your clot might be worsening, that's another. Like, that's not a direct adverse effect or side effect of being on a blood thinner. So it would be worth, if it's painful, if you're having, if putting your feet up is not helping, then you should definitely get in touch with your provider to let them know that this is new for you, and that, especially if this is something that started around the time of your, index, clotting event, and then is not getting better over time, or is in fact worsening, then that is definitely something that you would want to let your provider know, just sending them a message just to say, hey, is there anything else I should do? If you're elevating your feet, if you're, making sure that you are staying hydrated and it's not, working, then there could be some, problem with your blood flow, and it just would be good to give them a heads up.
Okay. Great. So we, of course, got several questions about COVID and how it relates to anticoagulation. So
Yes.
a kind of nice transition question that we had about INRs is, how do you, a lot of patients, we actually get a surprising number of patients that call us wanting to get home testing.
Yes.
For their INR and are having difficulty doing so. So can you kind of talk a little bit about what maybe the most direct path is to get home testing, and any helpful tips or tricks you might have to help these patients?
Yeah, absolutely. First of all, I just want to say, that, for the patients here that are joining in, like, this is, really great that you're participating in your care and getting your questions heard and answered. I think this is a really unsettling time with COVID, and especially when everything's shut down, you don't want to leave your house and you don't want to get monitored, because it's scary to go out and put yourself at an increased risk, especially because we know a lot of our patients, especially our warfarin patients, are older and have other comorbidities and would be considered in that high risk, and very, are concerned patients that we don't want you to contract the disease, because we don't want you to, fear getting sick, fear of getting put on a ventilator, because these things are very real, unfortunately, with this disease. So we want to do everything we can to keep you safe. I myself was actually in a very unique, situation when this all hit. My clinic was very stable and we were doing, great. And the end of February, I actually went out on maternity leave and signed out my clinic and had everything under control and wrapped up and tied in a bow. And then, I had my baby, and then 2 weeks later, everything shut down, and the clinic really had to step up and come up with new protocols to help get our patients tested, to help keep you safe. And, we really looked at things like extended interval testing. So if you had been stable, even if you liked to see our smiling faces and come in every other week to get your INR tested, we try pushing patients out 6, 8 weeks just to keep you home and keep you safe. We've also taken advanced directives in our clinic as well to make sure that, we used to book 5 patients every 15-minute slot, and now we book no more than 2, so that you don't see anybody else in the waiting room. As soon as you go in, you can get taken into a room, and at most we have 1 patient, maybe 2 in the waiting room at a time is the goal. And those patients can be, more than 12 feet apart, which is great. But for those patients that still don't want to come in and know that, we're in this for the long haul, that want to look into the self-testing, I totally get it. And we are here to help you guys with that. The first step is verifying with your insurance company that they will cover self-testing and which company they contract with, because some will allow it, others won't. The other thing that's
you say, just to clarify quickly, when you say which company they contract with, what do you mean by company?
So there's different home monitors. So we have the CoagCheck, we have the MDINR. So we want to make sure that we're, sending the paperwork to the right company, and that it's going to be covered, and that those costs are going to be affordable for your testing and your supplies. The other thing that's important to know, that if you are new diagnoses and going on warfarin for the first time, you need to be on therapy for at least 3 months before home monitoring companies will consider enrolling you. And it's just to show consistency with testing, make sure you're a good candidate, and that you're going to be on anticoagulation for an extended period of time. Because historically, like for DVT, for example, patients could go on, an anticoagulant for 3 months. And then if it was considered that they were treated, the clot was gone, the patient and the provider might decide to stop anticoagulation at that point. So they're not going to enroll you at time 0 and keep you on for 3 months and then have to go through all of the training, because it's a lot of work with the training, getting all of the paperwork done, getting you all the supplies, making sure that you feel confident in the self-testing, and also making sure that you have a stable INR. Because if you're just getting used to Coumadin 2, or your INRs are erratic, then self-testing might not be great for you either, because they're designed for stable patients. So many companies require that you only test, once a week or once every other week. So if you need to test, 2 to 3 times a week because your INR is unstable, or because we're trying to figure out what your weekly dose is, then you're going to run out of supplies before it's time to renew your, prescription for your strips. And so that can be an incurred cost as well. But typically, once we know that it's going to be approved by insurance, we, in my clinic at least, we fill out the forms for the patient with their diagnoses. So whether you have AFib or a hypercoagulable state, or whether if you've had a stroke or a clot, and then we will submit the paperwork to be signed by our medical director, or some clinics might send it to be signed by your PCP or cardiologist, which can also delay too. Like, we have a very good relationship because we have our medical director that will sign off on them for all of our patients. But if you have a center that is waiting to hear back from your offsite PCP or cardiologist, it might take a little bit of extra time too for them to get that paperwork, get it to the physician, get them to read through, sign it, and return it. And then once that's all done, depending on the lag, they, will process it as soon as they can. I think the companies are just trying to keep up with the increase in demand. because now with COVID, their request rates have gone up exponentially. So typically in the past, we used to submit the forms and patients within a week or two were being contacted. And I know some of our patients have said they're waiting a couple of weeks or months to, you know, get the date set up to be able to get their equipment and start self-testing. So I think it will depend on the peaks and lulls of their requests. But usually it's a very streamlined process once they get the paperwork, because they're happy to enroll the patients as well and set up the training pretty quickly.
Well, I think it's just helpful to know that it's not, you know, just kind of something that you're like, oh, you know, I'd like to start home testing. And it just is an easy process that, yeah, sure, no problem, anybody can do it. That, you know, there are certain guardrails and, you know, a process that needs to be followed, but it certainly seems like anybody who's on Warfarin and being managed by an anticoagulant clinic, this is an option for, you know, at least kind of discussing with your provider.
And the one patient population that we discourage and don't process for in our clinic and many clinics across the country is the antiphospholipid antibody patients.
Okay.
Because when you have that as your primary disease state and you are, you know, lupus anticoagulant positive, that can interfere with the test strip. So we don't let patients come to point of care testing either. We recommend that those patients go to the lab for blood draw only, because those results are the most reliable.
Oh, interesting. Okay. Great. Well, very helpful. Thank you.
Yeah.
So does being on an anticoagulant protect you from getting blood clots if you get COVID?
Another good question. So if you are on so taking a step back, what we know about COVID is emerging day to day, because, you know, we've been living in this life for the past 8 months now and still figuring it out, which it's crazy. But, you know, we don't have historical data from COVID to pull from. What we can pull from is our experience with the H1N1 flu and see how that compares, you know, just the severe acute illness. And what we know is that patients, you know, when they have COVID, there are a lot of inflammatory processes going on, markers like your D-dimer, your IL-6, your cytokines, they're all active and promoting thrombosis. So you're at this baseline hypercoagulable state. There can be some endothelial activity and activation, which is also further increasing that cycle. And then, you know, most of the times if you're laid out sick with COVID, you may be like laying down and, you know, not moving around. So the stasis, the vascular injury, the hypercoagulable state, it's all playing together to put you at risk for thrombosis. So one of the, you know, earliest things I looked at is patients that, you know, were hospitalized with COVID to see, you know, and they started seeing the increase in VTE events. And it's very too looking country to country between, you know, the Netherlands or the US or Italy. You're getting different data, so it's hard to even process everything all at once as well. But what we do know is that if you are hospitalized, you should be on at least prophylaxis. If you have no other indication for therapeutic anticoagulation, you will get prophylaxis when you're in the hospital. We know that patients that make it to the ICU do have a higher risk of DVT or PE than our ward patients or the patients on the floors. But we do see that giving you at least therapeutic doses of anticoagulation, or in some cases, intermediate or higher step-up doses of anticoagulants, or even therapeutic doses of anticoagulants, does have a benefit for patients in the hospital. Because what we're seeing in the US at least is that the rates of VTE, PE, or DVT are about 2 to 3%. So that is just something to keep in mind. If you are on therapeutic anticoagulation as an outpatient, then provided you have no contraindications to continuing it once you're admitted, we would keep you on it, because, you know, that would decrease your risk. And then the other, you know, and I will say too, I mean, there is a study that looked at out of New York, because we know New York had, you know, a ton of cases. And so they were able to get a lot of data together pretty quickly. And they looked at their patients that were on anticoagulation prior to their COVID admission versus those that were not. And there was no difference in mortality or like time to bend or things like that. So being on anticoagulation in general will help from a prophylaxis standpoint, from trying to prevent you from having a DVT or a PE. It can still happen, but your risk would be less than being on nothing at all. And then the other part of that too, I mean, once you leave the hospital, we're still trying to learn more about the, post-discharge risk of clot. We know that there have been a lot of studies looking at medically ill patients even before COVID hit to see if patients, when they leave with an acute illness, need to be on extended prophylaxis of anticoagulant. And the data right now is not really there. The guidelines aren't supporting use in all patients, maybe more so high-risk patients that have a low risk of bleeding. So that's very important. We're not going to prophylax anybody that has a high risk of bleeding. But if you do have a need and you are already on therapeutic anticoagulation at baseline, then that can be protective as well when you go home. So that's good to know as well, because it's not as high, but there's still about 0.5% risk of that they're seeing of VTE in at least the first 30 days after discharge. So
wow,
yeah.
Interesting. Do things, we're talking about COVID, but like the cold and flu virus themselves, can that impact the effectiveness of your anticoagulation?
So anytime we have acute illness, it tends to be a little more challenging to manage your INR. We don't have as much data with the DOACs, and we're hoping that as long as your renal function stays intact, you're not taking any interacting medications, that your levels should be stable. But we tend to find when you're having, an acute illness that, and a lot of times too, you end up going on antivirals or antibiotics or other medications to help treat that, cold or virus. And those things can also lead to fluctuations in your INR. So you may need to be tested more frequently when you're ill, because the illness itself can tend to drive up the INR. The concomitant meds that you're using can drive up the INR. So it can be challenging at times, because we'll have to decrease your dose temporarily when you're in the hospital and then try to figure out when you're better, that we can start, revving up therapy when your INR starts coming back down.
Okay.
But that being said too, I will make a little plug. Even if you just have a common cold or a UTI, or you're going, to see your doctor for something, and they prescribe you a new medication, don't assume that they have told your anticoagulant provider that you are on a new medication. You should always tell the person who is in charge of your warfarin about any new medications that you start on, because we may need to have you in sooner, or we may need to make upfront dose adjustments if we know that it's a drug that's either going to shoot your INR way up, or also possibly interact and cause your INR to go way down. So those things are very important. Sometimes we do have providers that are very good about telling us. Sometimes it's a couple of days later. Same thing if you have a quick, jump into the emergency room, like if you have a nosebleed or something else, don't assume that we will know or be notified that you were seen. You should let us know so that we can touch base with you and see if we need to make any adjustments or get you in for a test. I think that's all very important, because sometimes we don't know, and then a patient might start an antibiotic. You feel fine because you're not going to feel any different, but then we come in and we check your INR, and it might be all of a sudden 4 or 5, and we're saying, oh my gosh, what happened? You were so stable and we were doing so great, and then you say, oh yeah, I started this other medication 3 days ago. And we say, oh, if we had known, we could have potentially prevented this. So it's always nice to know. Like we would see that a lot too. Not that there's necessarily anything to do for short courses, but when people would go on Tamiflu and not let us know, and we're testing right in the middle of their course, we would see their INR go way up and then have to try to manage that temporarily.
And what you said earlier about nosebleeds, I mean, I think when you think of anticoagulants, you tend to think of these really major tragic bleeds, like a major head bleed, but nuisance bleeding can be a real issue for patients. And I know having had nosebleeds myself, especially this time of year when it gets really dry, they can be really scary. So I know that's definitely a consideration too. Just a plug for the NATF website. We have a great video on there about how to treat a nosebleed if you're on an anticoagulant and when to seek medical attention for that. So I think that's really helpful. But yeah, I think nuisance bleeds are an issue for patients.
Yeah, no, I agree. And I think, letting us know if they're starting, because, at least we can keep an eye and make sure that if you're telling us you're starting to get nosebleeds and we notice that your INR is running, 2.9, 3.2, we can try to drop you down a little bit on the lower end of that goal before you end up in the emergency room or urgent care needing packing instead of just, some tissues and some pressure. So those kind of things are important. And same thing if you notice changes in your GI, like if your, stools are dark and tarry, if you're noticing blood in your urine, those things you need to tell us, because sometimes we just hear like, oh yeah, my stomach is upset or I'm not feeling well. And then, we find a note, a day or two later that you went to the emergency room or had to call your doctor. And then, we find out that you've experienced a little bit of bleeding or experiencing blood in your stools and, need to get a scope to see what's going on. So the sooner we know, the sooner we can reach out to your providers to let them know that there's a problem and hopefully get you looped into the system before it becomes more of an emergent case.
Just another instance of open communication and how important that is.
Yes, I'm a huge fan. The more we know, the safer you will be.
Great. Well, I think we're right up against 8 o'clock, so I'd like to ask all, our presenters kind of any, final words for the group tonight in terms of, just anticoagulation or, whatever advice you want to leave us with.
I think it's kind of the theme of the night is the shared decision making, making sure that you are comfortable and confident in your provider's choice for your anticoagulant therapy, knowing that you can always ask questions if you're worried about your risk, and making sure you let us know about your other medications that you're on, if cost is an issue, and what kind of fears you have. Like, if you're worried, sometimes when we see our patients, they're both high risk of stroke and high risk of bleed. So how do we kind of manage your expectations, and what scares you more? Sometimes people might look at you and say, oh, you're high risk for an anticoagulant, I'm worried about your bleeding. But when you say, that's fine, like treat my bleed, I'm very worried about having a stroke or having another PE, the first one almost killed me, then we know we need to, put you on a medication, and we know we need to really do a deep dive into see which is the best one. Because even though there's 4 different NOACs, one thing I like to tell when I have my trainees with me or my team is that this is a special class of medication. So it's not the same as an antihypertensive class. Like, many patients might be on ACE inhibitors. If your doctor said you need to be on an ACE inhibitor, they can choose any one, whatever's preferable to you, once a day, twice a day, whatever's on your insurance's formulary. But when it comes to the DOACs, even though they're all blood thinners or anticoagulants, they each have a unique profile, unique ways that they've been studied, unique metabolism, clearance, drug interactions. So we can and need to tailor therapy based on your risk factors and based on your lifestyle. And so I think that's what's most important. It's not a one size fits all approach to care when it comes to your anticoagulation treatment plan. And if you start on something and it's not working for you, don't stop. Just talk to us and see if we can redirect and find another way to treat you. Because there are other options, and there are so many people that can be a part of your care team, whether it's the nurse in the clinic, your pharmacist, your cardiologist, your vascular medicine doctor, your internist. We all want to work together to keep you safe. And that's the goal. So when you tell your nurse or a pharmacist like myself your concern, I don't just say, oh, okay, good to know, write it on my little chart. I take action. Like, I will reach out to your providers with a plan. And that's what a lot of us, thoughtful, caring anticoagulation providers want to do. We want to say, hey, your patient came in and talked to me and told me that this was a challenge for them, or they don't feel good when they're taking this medication, or they can't afford this anymore, or, you know, they're not feeling well, I think we need to check labs. And that's what we do. We loop them in and we help us to make the right decision for you. You know, we'll make recommendations, and I think that's the thing. It's a team-based approach, and we're always here, you know, to treat you, help you, and keep you safe, especially during these crazy times.
Yeah. Well, I think I read something recently that really resonated with me. It was like, you know, when you're talking about a clinician and a patient, you think that the power kind of lies with the clinician because they're the expert. But the patients are the ones that are the expert on their own body and their own circumstances. So it's really important that patients feel empowered to speak up and, you know, be an active participant in their care.
I agree 100%.
Yeah, great.
Be your own advocate.
Tara, this was great. Thank you so much for your time this evening. We really appreciate all your knowledge and your wisdom and your passion. I mean, you know, if I ever have to have an anticoagulation specialist, I hope that they're as caring, you know, and compassionate as you are. So
thank you
so much for your time this evening. And thank you to everyone that joined us. And your terrific questions. They're always thought-provoking. We will be doing another Ask the Expert next quarter. If you have any topics that you would like us to address, feel free to email us at events@natfonline.org, or you can reach out to myself or any of the staff members directly. Thanks so much, everyone. Thank you, Tara.
Thank you.
Bye-bye.
Bye.